This is a one-eyed patient. The other eye vision is PLPR, lost to glaucoma. This eye trabeculectomy was done 10 years ago. Currently on full treatment with brinzolamide and brimonidine, travatan, and timolol. Um, Required a cataract. She had postponed this surgery for a long time, being one-eyed. Breaking the synechiae, and despite 100 cc of mannitol being given, the positive pressure is tremendous. The AC is really shallow, and also the IOL power is 30 diopters. So it's a very small eye with shallow AC, history of glaucoma, severe positive pressure, posterior synechiae. Fields are also constricted on full medication. Trap done. When you have cases where a previous surgery has been done, there are all sorts of adhesions and one has to tackle them also. The eye sometimes behaves in funny ways. You will get an idea of the positive pressure when I introduce the phaco probe. Making sure that the entire axis is out so that it doesn't extend to the periphery. See, on doing hydrodissection, you can see the iris is trying to come out. One-eyed patient, you don't want to try reducing the pressure by any other methods entering the vitreous cavity. You can see the resistance the phaco probe is facing to enter. So I retract the iris from below it so as to give a comfortable entry, and blocking the main incision so as to prevent the floppy iris from leaving the eye. As I said, when a previous surgery has been done, there are some weird adhesions and the nuclear material, cortical material behaves in a very sticky format. This looks quite easy, but do remember that constantly one is having to face the shallowing of the AC and tremendous positive pressure. In this case, the initial steps are easy, but when you come down to the last piece of the phaco fragment, one has to be extra careful because the PC is just waiting to come into the phaco port. At this stage, just reduce the flow, go very slowly. This is the point where there is a surge and one can catch the PC. You've successfully completed the phaco. Now the cortex is always very sticky here and adherent due to the previous surgery. In this case, the irrigation aspiration is the harder part than the phaco. Again, because of the positive pressure and the PC touching the aspiration probe just a millimeter down, and you can cause a rent. You can see the chalky white optic disc flashing from behind. These irises, which have posterior synechiae and operated for TRAB, also have a tendency to bleed. Patients with glaucoma, you see endo sign. Therefore, you have to be very careful not to even, you're very careful not to do this. And that is catch the iris with the aspiration probe, because if these start bleeding, that becomes another whole task to manage. Then you have to do an air tamponade to control the bleeding and then proceed with the case. So positive pressure there, trying to hold and retract the iris. You have to be very careful with the irrigation cannula not to puncture the PC. So it was not coming out, therefore retracted it with the irrigation cannula so I can get a better visualization as the pupil is small, and then remove the entire cortex. This I'm going ahead putting an eyehance, as she is one-eyed and wanted to give her distance and a little intermediate vision. Pupil is small. You have to just make sure that you have positioned it properly in the bag. Now I find that there is a little flap there of the anterior capsule, like a triangular flap, so I'm cutting it with the micro scissors. Not very happy with it flapping around in the center. Using a micro forceps, vitrectomy forceps, holding that little flap and tearing it and taking it out. You can see it. So I didn't want anything to come into that pupillary area. After debulking the eye, the pressure has reduced as the cataract is out and the lens occupies lesser volume. Chamber is stable, no bleeding, no iris chaffing. All in all, went well. Due to handling the iris.